good to be here. It's a pleasure to be here with you today, and I'm honored truly to be speaking at this session organized by such a great team, mashallah, Sasa Muslim Student Club. I want to thank Dr. Abdo, Dr. Sulafa, and the team for the great coordination and collaboration. Allah يعطيكم العافية يكتب أجركم. Today's lecture طبعا focus on respiratory emergencies, and as you all know, guys, respiratory system from the emergency medicine point of view is one of the most critical and time-sensitive areas that you have to pay attention to. فمهم جدا أنكم أنتم you master emergencies in pulmo, as it's one of the most common emergencies. I hope this session, inshallah, will build your confidence in managing real-time, real-life respiratory emergencies. So let's get started. These are the outlines of our today's talk. We're gonna start with cardinals that are relevant to the respiratory system. Then we're gonna take a glimpse about acute bronchitis, followed by pleural effusion and pneumonia. After that, we're gonna take like a couple of minutes break, followed by ARDS. We'll be back on RDS. RDS as one of the commonest complications of lungs emergencies. Then we'll talk about tuberculosis, how to manage patients with tuberculosis, then pneumothorax. After that, we're going to know or recognize the differences between asthma and COPD from an emergency medicine point of view, and how to manage each patient and each entity. So let's start with the first outline. First outline is cardinal presentations, namely fever, cyanosis, sore throats, and hemoptysis. So let's start with fever. Can anyone tell me what's the definition of fever? Yeah, I want to listen from you. Anyone?
It's an increase in the body temperature, often due to illness or associated with some symptoms.
Excellent, excellent, Lynn. So is there any cutoff, any number? Whenever it's exceed that number, I mean the temperature, if exceeds that number, we consider it as fever.
37.5 to 38.
Okay, 37.5 to 38. So I'm gonna take a number in the middle, 37.8. Excellent, well said. So if the temperature is more than 37.8 Celsius and the patient did not take antipyretic, this is considered fever. Okay. There are like several mechanisms of heat loss, but the most common ones عندنا تقريبا 4 mechanisms. Okay, as you can see on this picture, the first mechanism of heat loss is radiation, where the heat trapped beneath the skin get outside to the surrounding environment. Okay, convection is the second mechanism of heat loss, means when there's like a radiation source from a cooler surface like fans or something directly toward and hits the body with a fever or high temperature. The third one is evaporation. Evaporation mainly through sweating. Okay, those patients present with high temperature, they usually sweat, and this sweating is a normal physiologic response from the body to get rid out of the high temperature that trapped inside the body. And the fourth mechanism of heat loss is conduction. And you know what, as the name implies, conduction means when the body directly get contacted with a cooler surface. This is another way of how to lose these heats. Okay, great. The best method to measure temperature in emergency department is rectal. Okay. And the way how to manage patient with fever apparently is by giving paracetamol, okay, as the medication to start with. And the rationale beyond that is prevent neuronal damage and subsequent neuro sequelae. Okay, this question is for you. What's the difference between fever and hyperthermia? And I'm sure you hit the term hyperthermia. Is it the same? Is there any difference? Yeah, anyone? I can see the chat box. Please, if there is anything written there, let me know. Anyone can open the mic and just read whatever been written in the chat box, please.
Okay,
Yes,
Enough said hyperthermia could be associated with heat stroke. Faris said hyperthermia caused by external factors. Bayan said fever is due to infection. Hyperthermia is increase of body temperature. Enough said and reach high reading like 40 for hyperthermia.
Excellent, excellent, excellent. Okay, all of you are right. And here is the clarification of how to differentiate between fever and hypothermia. From the pathophysiology point of view, fever, when there is like extra source, like for example, infection, hits the body, okay? This in turn will trigger the leukocyte, and leukocyte will activate the interleukin-1 and prostaglandin E2 at the level of hypothalamus and raise the set point. So apparently fever caused by apparent infection or obvious infection, okay? And something can be managed by antipyretic, paracetamol or NSAIDs. On the other hand, hyperthermia, for example, in case of heat stroke, this will melt down or this will damage the set point that is located in the hypothalamus. So this is directly affect the set point that is in the anterior hypothalamus. And set point works as the switch of body temperature change and response. And whenever the set point get damaged, injured, or melt down, the response to paracetamol or NSAIDs will be weak or even null. Okay? By other word, fever, they respond to antipyretic. Hyperthermia, they wouldn't respond to any medications. Rather, the management of hyperthermia patient is cooling techniques. Okay, cooling techniques. So here is the difference. I hope it's clear. If there is any question, just open the mic at any time and speak loud. Okay, moving to the second cardinal presentation, which is cyanosis. What is cyanosis? Does anyone tell me what is cyanosis?
can I answer?
Please.
It is bluish of the skin due to hypoxia.
Okay. Excellent. What else? I want to take much time. Cyanosis happens when the unoxygenated hemoglobin in the blood equals or even exceeds 5 gram per deciliter. Okay, and we have two types of cyanosis, either central or peripheral. How would you differentiate clinically central from peripheral cyanosis? How do you know this is a central or peripheral cyanosis?
By physical examination,
Okay.
as central, you will see it in the mucous membrane in the mouth. Peripheral, you can by physical examination of the peripherals, hands.
Excellent, excellent, excellent. If the bluish discoloration involve the oral or perioral cavity, if it involve the nasal or perinasal region, or even the central of the body trunks. This is called central. Peripheral, when the bluish discoloration at the peripheral sides of the body, mainly the limbs. Okay, perfect. Central, here is the thing. Pathophysiologic point of view, there is a difference. Central happens when the hemoglobin oxygen dissociation curve shift to the left. Okay, shifting of this curve to the left means less oxygen delivery to the tissue. Okay, that's lead to central cyanosis. On the other hand, peripheral cyanosis is caused by vasoconstriction of the limbs. Okay, and that extreme vasoconstriction lead to slowing of the arterial blood flow and might cause subsequent limb ischemia. So it's very important to differentiate between central and peripheral cyanosis, and that starts from the clinical picture of the patient. There is like one critical question per each type of cyanosis, okay, where you start your approach for such patient. يعني, in case of central cyanosis, always ask yourself, is the patient looks sick? I mean, looks distressed? Is the patient looks distressed? If the answer is yes, so the most probable cause of that cyanosis is the lung. Okay, for example, asthma, severe asthma, pulmonary embolism, pneumothorax. Okay, if the patient is having central cyanosis but looks well clinically, that means the cyanosis most probably originated from the heart, like in case of heart failure, cardiac shock. Okay. So this is how to approach patient with central cyanosis. In contrast, peripheral cyanosis, the critical question is, after placing the patient on oxygen mask, is that oxygen improved or not? If the oxygen get improved, that means what? That means the patient must probably having shock. Okay, shock. And you have to trying to like sorting out what type of shock and manage accordingly. If the patient is having peripheral cyanosis and not improving with oxygen supply, here where you think about vascular occlusion, you must think of vascular occlusion. Okay, and you involve the vascular surgeon early in the course, and you start your unfractionated heparin therapy. I hope that's clear.
Clear.
So the management basically start with oxygen supply. If the patient looks dehydrated or in hypovolemic status, so you start them in fluids, and as I mentioned earlier, if there is like a picture of limb ischemia, that basically you manage the most likely cause based on your initial approach at the emergency department. Okay, great. There is one subvariant from cyanosis is called methemoglobinemia. Okay. Methemoglobin is a type of hemoglobin, normally exists in the body, but it should be less than 1% of the total hemoglobin. Okay. When the percentage of methemoglobin exceeds 10%, here the patients will be labeled as having methemoglobinemia. Okay, again with same mechanism, methemoglobinemia, same mechanism of central cyanosis, shifting of the curve to the left that lead to diminished oxygen delivery to the surrounding tissues. Okay, this is the classic blood sample of a patient with methemoglobinemia. Can anyone tell me what you can see on the left sample, on your left, the one on your left?
Dark.
Okay, dark. Excellent. So it's darker than usual. Perfect. What else?
In the comments, they're saying chocolate color.
Excellent. So this is like a typical finding of patients who's having hemoglobinemia after taking blood sample, something called chocolate brown blood. Okay, because the colors tend to be like chocolate brown. Okay. Perfect. We'll say oxygen saturation is 85%. This is a typical number in a patient with methemoglobinemia. Okay, it's a constant number. Okay, if patient present with cyanosis and you place or attach that pulse oximeter to the patient's thumb and you find that the patient is having oxygen of 85, nothing more, nothing less, here you should raise suspicion of methemoglobinemia. Okay. And how to confirm the diagnosis? You take a blood sample, you analyze it with blood gas, looking at the methemoglobin level, okay, and the oxyhemoglobin as well. So oxygen saturation is an unreliable method of measuring the oxygen, and the pH and CO2 as well in the blood gas are reliable measures. Okay, the thing of how to diagnose patient with methemoglobinemia is by measuring the methemoglobin level and the oxyhemoglobin level and the VPG. Okay. The management of patient with methemoglobinemia is giving methylene blue, but not all the time if indicated only. What are the indications of methylene blue?
G6PD.
Come again?
إذا كان البيشنت symptomatic
Okay.
أو الميثيموجلوبين to hemoglobin ratio is more than 30%.
Excellent. So if the methemoglobin level is more than 30% regardless of symptoms, or if the methemoglobin level is more than 15% and the patient is having symptoms. The second indication is symptomatic hypoxia, okay, especially the malignant arrhythmias. Excellent, Louis. Great. Do you have any question? Fevers,
I just want to say that we cannot give methylene blue if the patient had
If the patient, again?
Have G6PD.
Excellent. Yes, that's true. This is one of the leading cause of hemolysis in G6PD, giving methylene blue. So if patient with G6PD present with methemoglobinemia, management should be coordinated with a hematologist. Thank you very much, Doctor. Thank you. Okay, moving forward to the sore throat, the third cardinal presentation is the respiratory system. Okay, most common cause of sore throat is viral. Most common cause is viral. Most common cause is viral. What does that mean? It means most cases managed conservatively. No antibiotic is needed. Okay. The most common virus is rhinovirus. The most common bacteria is group A strep. And you, as emergency physician, must think and rule out these emergency and critical diagnoses. Okay. Always ask yourself, does the patient have a possibility of having epiglottitis, retropharyngeal abscess, or other deep neck infections? Or does the patient have acute coronary syndrome? This is really important. Acute coronary syndrome can be one of the causes of sore throats. Okay, yes, it is rare, but it's still there. Okay, sore throat patients should what? Any sore throat patient should what? Undergo ECG. You should order ECG for any patient present with sore throat. Okay, this is the best way to approach patient with a sore throat from an emergency perspective. Patient present with sore throat. First question is, does the patient have any sign of airway compromise? If this is the case, then you should involve the otolaryngologist early on board. Okay. If the patient is stable enough to do imaging like CT with contrast, go ahead. If the patient does not stable enough to move him to the CT suite, then you consider intubation. Okay. But not in the emergency. Intubation should be done in the OR. Back to the first question. If there is no signs of airway compromise, second question is, does the patient have pharyngitis? Clinically, does he or she have a signs of pharyngitis? If it's yes, then you should apply modified center criteria. We're going to talk about in a minute. If there is no signs of pharyngitis, then you should think of other diagnoses. First of all is acute coronary syndrome. Okay, so ECG should be done here. Perfect. Modified center criteria is like it's a criteria that consists of 7 elements, each of which has its own like score. Okay, and based on the results or a score, you decide your next step. If the score is 1 to 2, this most likely the cause is viral, so the management is supportive. If the score is more than 2, the next step is throat culture or rapid antigen test. If any is positive, you start with antibiotic. If negative, then no antibiotic is needed and the patient should be managed as viral infection. Supportive management. Okay.
Doctor, why don't we
Yes,
start
please.
with the antivirals?
Come again, please.
Since it ما يعني الفيرال هي اكثر شيء، ليش ما نبدا بالانتي فايرالز؟ ليش antibiotics؟
Yeah, طبعا you don't have lots of antiviral options, and not all viral has a specific antiviral therapies. Okay, as the most common virus that could cause sore throat is rhinovirus, there is no antiviral therapy against that viral up to date. Okay, up to my knowledge. But if the sore throat is associated with one known disease that it has like antiviral therapy, for example, what is that? Any chest infection that has like a specific antiviral therapy, okay? You start with the antiviral. Otherwise, it's supportive. Supportive means if the patient is having like body aches, fatigability, fever, you give him just a paracetamol, and you advise for close follow-up with the primary healthcare. Okay, because like and there is actually another approach for such patient, something called safety net prescription. You discharge the patient on antibiotic. Okay, initially you just instruct them that they most likely cause viral, the management supportive, but if your condition doesn't improve or getting worse in the next 2 days, then you start the antibiotic and seek advice from the primary healthcare. I hope that's clear, Doctor.
جزاك الله خير.
Okay, great. If there is like signs of airway compromise, you know it. You should secure airway. You should involve the otolaryngology and anesthetist as early as possible. You should position the patient upright, start antibiotic and steroid right away. Okay, this is the first thing to do. If the patient is simply having pharyngitis, so if it's viral, as we mentioned, support, if it's bacterial, we said bacterial antibiotic, so we have like few options of antibiotics. Namely, you have IM penicillin G or oral amoxicillin or penicillin V. And you might consider as well dexamethasone, okay, IM steroid in case of severe pharyngitis. Oral dexamethasone in case of severe pharyngitis. This will help a lot. Okay. Any question in sore throat? All good?
All good.
Okay, perfect. So now let's talk about the last cardinal presentation in the system, which is hemoptysis. Hemoptysis basically has two types, minor and massive. Okay, minor hemoptysis uh, is when the definition of massive hemoptysis is not met. Okay, and we're gonna know the definition of massive hemoptysis in a while. But minor hemoptysis is most commonly caused by acute bronchitis, and the most common origin is tracheobronchial capillaries. Okay, and the how to reach the diagnosis is clinical, and the management is supportive. But if the patient is showing signs of bacterial infection, okay, like sputum with cough, like a temperature fever, at that time you start the patient on azithromycin and bronchodilator, of course, if there is wheezing clinical exam. Massive hemoptysis, on the other hand, is when, can anyone tell me? Anyone can define what is massive hemoptysis?
100 to 600 mils of blood.
Again, Loy, I couldn't hear it.
100 to 600 mils of blood.
100 to 600 ml of blood. Okay.
Yeah, I think in one day.
In a day. Okay. Other thoughts?
A single spit of blood more than 50 cc.
Excellent. Super. So the definition of massive hemoptysis when single expectoration more than 50 ml or expectorations more than 600 ml per day. Perfect. Most common cause is tuberculosis in the rural areas, while lung cancer is the most common one in urban ones. Okay. Most common origin of massive hemoptysis is small caliber bronchial arteries. Okay, and as you all know, smaller the caliber, higher the pressure, and faster losing the blood. Mortality rate is very, very high if the patient is not managed well and in a timely manner, reach up to 80%. And the most common cause of death is asphyxiation. Okay, asphyxiation from the blood. So hypoxia is a warning sign. Hypoxia is the most concerned vital sign. This is how to manage it, how to diagnose first the patient with massive hemoptysis. Okay, the first thing to do is a chest X-ray. It's very important. Chest X-ray, if it's positive, if it's showing like a clear link pathology that could lead to massive hemoptysis, then you refer the patient to the proper specialty. If the chest X-ray is negative, then the next step is CT with contrast. CT chest with contrast. If the CT chest with contrast is positive, then you manage accordingly. You refer the patient to the proper one specialty. If the CT contrast is negative, the next step is bronchoscopy. Bronchoscopy is the gold standard and the most definitive one. So the serious actions of diagnosing patient with massive hemoptysis starts with chest X-ray, if negative CT contrast, if negative bronchoscopy. Okay. Okay. This is a chest X-ray of a patient who presents with massive hemoptysis. Can anyone tell me what is the abnormal finding and what is the most proper line of management? Saying that the patient is stable.
دكتور معلش بس Zahra is asking how we start chest X-ray while he is on massive. Shouldn't we start bronchoscopy?
We are talking about stable patients. If the patient is unstable or if the patient is having ongoing massive hemoptysis, this is another story. Okay, we're gonna talk about how to manage such patients. Yes, Dr. Lama, please.
طيب حيكون عندنا أول حاجة على الليفت سايد في two opacities في
Okay.
الأبيكس and it might be the upper loop and also all the bilateral arbitration of the costophrenic angles.
Okay, great. Excellent, Dr. Lama. So what we can see here, mainly, I mean, the pathologies that link to the massive hemoptysis most probably is due to, Dr. Lama?
TB.
Okay, TB or
TB or cancer.
or cancer, excellent. So if the case is cancer, if the most probably cancer, طبعا هذه you should طبعا link it always to the patient presentation صح ولا لا؟ إذا patient جاي presentation of cancer and you find this in chest X-ray, so what is the proper disposition of this patient?
He should be admitted.
Under
ICU.
Before ICU, if the patient is very stable, what is the most probable specialty that could take care of this case?
Pulmonology.
Or excellent.
medicine.
Pulmonology or oncology, excellent. And if the case is TB, again, pulmonology or internal medicine. Okay, super B. Thank you. Okay, this diagram shows how to manage a patient with stable massive hemoptysis. Here, where we should start with bronchoscopy, دكتورة رسالة. So bronchoscopy is the best initial method to start with in such case. Okay, if the hemoptysis get controlled by bronchoscopy, alhamdulillah, should start supportive management, watchful waiting, and area of observation. If the things is not controlled or getting worse, the second line is to involve intervention radiologist, okay, to do something called bronchial artery embolization. Okay, if controlled, fine. If it's not controlled, then the last results, the last resort management line is taking the patient to OR for thoracotomy. In case that the patient is unstable, so you as emergency physician should do step 1 and 2. Okay, so you should start with the primary survey, send for type and screen, establish IV lines and start fluids. If there is any history of coagulopathy, so you start reversal of that coagulopathies. After that, you place the injured lung down, okay, because blood goes with gravity. So you want to protect the healthy one, and the healthy lung should be at the top. Then you intubate the patient using size 8 endotracheal tube to the healthy lung. Okay, why size 8? Why size 8? Size 8, by the way, is a big one. Okay, why we use size 8 in patient with massive hemoptysis?
Bronchoscopy.
For bronchoscopy, so this size of the tube actually allow the passage of bronchoscopy through without any struggle. Excellent. And bear in mind that always anesthetists should be around as a backup team. Excellent. Step 3 is the first and the best method of managing patient with unstable massive hemoptysis, which is bronchial artery embolization by the intervention radiologist. Okay, if things get controlled, fine. If not, then OR thoracotomy is the way to go. Do you have any questions so far? Things are clear? Not clear?
Yes, clear,
Please.
Doctor.
Okay. Any question in the chat box? Please let me know.
Yeah,
Sure.
Doctor, I have a question.
Please.
How we can differentiate if the blood is hemoptysis or the patient is vomiting blood, not coming from the lungs.
Okay, excellent question. It's based on the patient complaint. Okay, if the patient is coughing, so this is hemoptysis. If the patient is vomiting, so this is hematemesis. Answers your question? And either way, a chest X-ray should be done. Okay, and either way, chest X-ray should be done. And usually, patients with hemoptysis present with respiratory symptoms. I mean, associated respiratory symptoms. Okay, patient present with a GI bleed, usually present with different color blood. Okay, something called coffee ground. Vomiting. So the characteristic of the vomitus itself is totally different from hemoptysis. Hemoptysis, usually they are coughing, frank, fresh blood. Okay. I hope this answers the question.
Yeah, thank you.
Okay, great. Let's move to the second. Please, anyone want to add something? Want to say something?
There a question.
Yeah, please.
Just 1 minute. في واحد بيسأل method of intubation in massive hemoptysis, direct or glido.
Patient with massive hemoptysis ايش؟ مرة ثانية معلش.
Of intubation in massive hemoptysis, direct or glido.
This is excellent question. What do you think?
Direct.
Direct. Why?
لأن it will the visualization will be not good by camera. يعني it will
Thank you
obscure
very
the...
much. Thank you very much. Excellent, Doctor. What's your name?
دكتور عبد الله.
حياك الله يا دكتور عبد الله. Excellent, Dr. Abdullah. So if you use a gyroscope or video assist device, the blood will obscure the vision on the screen, so you wouldn't see anything. And this will delay the time of successful intervention and managing the patient. So it's very important to use direct laryngoscope with continuous suction. It's very important. Other questions?
No.
Okay, perfect. Moving to the second outline, which is acute bronchitis, just in one slide. Okay. The most common cause of acute bronchitis, again, is viral, mainly influenza A and B. Okay. Here, if the case is influenza A, دكتور اللي سألني عن antiviral, so you might consider Tamiflu. Okay, therapy. And there is a clear association between the sore throat and the influenza A as initial presentation. يعني أحيانا البيشنت يجيك يشتكي من sore throat initially, وبعدين after like a couple of days start to have this chest sign and symptoms. Okay, here where you should do this swab and rule out the influenza A. Okay, the typical feature of acute bronchitis is cough that is persistent more than 5 days. Okay, cough more than 5 days should raise suspicion of acute bronchitis. If the cough is less than that, we call it common cold rather than acute bronchitis. Okay, however, the management is the same. It's very important to make sure that the patient is not having pneumonia, because the most common cause of pneumonia is bacterial, and the patient should be started on antibiotics in such cases. So very important that you know that acute bronchitis is persistent cough more than 5 days without evidence of pneumonia. So basically the diagnosis is clinically, and if you think of pneumonia, you do chest X-ray. Okay. And the management, because you know the most common cause and most likely cause is viral, again supportive. If you suspect bacterial, then you start the patient in azithromycin. Okay. If the patient is having concomitant like wheezing and your clinical exam, so you prescribe a bronchodilator for the patient with the antibiotic. Perfect. Any questions so far? All good?
Oh,
Okay, so now we're gonna take 1 minute, okay, like short break for stretching out, okay? Then we'll be back in a minute. Okay, so now let's resume. Um, let's now talk about the pleural effusion, okay? And starting with this chest X-ray. What can you see here? What are the abnormal findings in here?
There is obliterated costophrenic angle.
Okay, unilateral, bilateral?
Bilateral.
Excellent. What else?
Cardiomegaly.
Excellent. Cardiomegaly. Perfect. What else?
someone said infiltration. Leon.
Okay, bravo. Bravo. What else? Excellent.
Prominent vessels on both sides.
Bravo عليك. So you can tell, okay, the abnormal finding, which is mainly the pleural effusion, and you can tell the cause from the chest X-ray. What is the most likely cause of the patient's pleural effusion?
Volume overload.
What do we call the disease?
Heart failure.
Heart failure. Excellent. Excellent. Great. Great. So pleural effusion characterized by fluid between the two pleura, okay, visceral and parietal. This will lead to obscured costophrenic angles. Okay, this is a typical finding on chest X-ray. Okay, you said it all. Great. So the most common cause of pleural effusion worldwide is heart failure. Okay, and the causes of pleural effusion either transidate or exudate. If the transidate is the case, so the most probable cause is heart failure or organ failure in general. Cardiac is the most common among all. If exudate, cancer is the most common cause. Other causes, infection and drugs like amiodarone. Patient classically present with dyspnea, pain with respiration, decreased breath sound at the side of pleural effusion. How to diagnose patient with pleural effusion? You start always with having this chest X-ray. Okay, so as the best initial test, lateral decubitus is the best. Okay, because the fluid is gravity dependent. Okay, it goes with gravity. That's why lateral decubitus is the best. Supine is the worst. Why? Because the fluid could be unseen if the amount is low, as these fluids can be hidden beneath the lungs. So avoid supine view if you think of pleural effusions. Ultrasound is more sensitive than chest X-ray. ليش؟ لأني أنا في الشيست إكس راي أحتاج أقل شيء 150 ml عشان أنا أشوف pleural effusion. أوكي. بينما في الألتراساوند أنا أحتاج as little as 50 ml عشان تبدأ تبين معي. أوكي. That's why ultrasound is more sensitive than chest X-ray. Can anyone tell me what is the typical sign of pleural effusion and bedside ultrasound?
B lines.
B lines. Pleural effusion. مش pulmonary edema.
Spine sign.
Spine sign. Excellent. Spine sign. Okay. Look at it. It is very important. Just YouTube. Then write spine sign bedside ultrasound. You will see how does pleural effusion look like an ultrasound screen. CT chest is the gold standard. Okay, CT can detect even smallest amount and sometimes help you to figure out the cause. Diagnostic thoracocentesis is not always indicated in the emergency department unless no clear cause, and it considered exudates if one or more of the following. I think you know it. What do we call this criteria? What do we call it? In the chat box, someone wrote something.
Light criteria.
Lights criteria. Thank you very much. Excellent. Okay. Managing patient with pleural effusion mainly toward the cause. If pleural effusion is caused by heart failure, so you manage patient as heart failure. Pleural effusion is caused by pneumonia, you start the patient management of pneumonia, and so on. Okay. Except in one condition, if the patient is having pleural effusion and he is dyspneic at rest, this is the only indication to do therapeutic thoracocentesis. It's very important. Okay, like if you do chest tube and you drain about 1 liter slowly, okay, till the patient symptoms relieved. In certain conditions, like if in a patient with comorbidities, significant comorbidities, patient received antibiotic but failed to that antibiotic, patient is having a pleural fluid pH less than 7.1. This is per se raise the suspicion of something called empyema. Empyema is a very bad and nasty kind of infection in the lung. Okay, or even if the chest X-ray shows effusion more than 50% of the thorax. Okay, like the case here. I can tell that the left lung is 100% affected by pleural effusion. This is an indication of for this thoracocentesis, if the patient is having dyspnea at rest but with large pore tube. Okay, because you know empyema is a thick type of infection. If you use smaller tube, it's going to be blocked easily and fail the procedure as well. Okay, pneumonia. Pneumonia is one of the common presentation in the emergency department. No brainer. I think إنكم كلكم agree معي. I think إنكم كلكم شفتم patients with pneumonia. Okay, pneumonia per se it has like different types with different definitions. Okay, is it important? The answer is yes. It's very important to figure out the type of pneumonia early from the history and physical exam, as the management is different. Okay, so the type of pneumonia will guide your management. Community acquired pneumonia, you all know the patient present with signs and symptoms of lower respiratory tract infection and no history is given of recent admission. hospital acquired pneumonia إذا pneumonia صارت بعد يومين من الادmission. This is really important. Okay, so this is something nosocomial, something in hospital. Third type is healthcare associated pneumonia. Healthcare associated pneumonia, this is one of the most important kind of pneumonia that you should always keep in mind and always ask the patient or try to figure out if the patient is having this type of pneumonia or not, because HCAP or healthcare associated pneumonia is the worst among all. Okay, having the worst type in term of mortality and in term of antibiotic resistance. Okay, and كيف حنا نعرفها؟ هل في history of admission more than 2 days in the last 3 months؟ نسأل clearly أنت آخر 3 شهور تنومت يومين أو أكثر؟ If the answer is yes, فهذه غالبا تكون healthcare associated pneumonia. Other definition of healthcare associated pneumonia إنه البيشنت اللي frequent visitors to the hospital for whatever the reason، يعني مثلا hemodialysis، مثلا course of antibiotic, patients receiving chemotherapy في last طبعا month، هنا برضو نعتبرها healthcare associated pneumonia. The fourth type is ventilator associated pneumonia. This is really important. هذه تشبه الهوسبيتال اكوارد نيمونيا، نفس الكونسبت ان النيمونيا تصير بعد يومين من الادميشن، ولكن في الفنتليتر اسوشيتد نيمونيا اعتقد من اسمها ان البيشنت يكون انتوبيتد. Okay, intubated, and we blame that tube as a causative source of the pneumonia. The last type is something called aspiration pneumonitis / pneumonia. Pneumonitis is irritation of the lung parenchyma without infection. Okay, while if thing progressed يعني من acute pneumonitis, patient might develop this aspiration pneumonia, which is طبعا هذا type of genuine pneumonia where antibiotic is indicated in such cases. What can you see here in this chest X-ray? أحتاج أسمع منكم. What can you see here?
Right lower lobe consolidation or patch.
Excellent. What does it indicate?
Lobar pneumonia.
Pneumonia.
Okay. What type of pneumonia most likely?
Lobar.
Aspiration pneumonia, maybe.
If I tell you that the patient is young, healthy, and is giving a history of upper respiratory tract infection in the past week.
Community acquired.
Yeah, community acquired pneumonia. Thank you. Okay. This is a typical pneumonia. Okay. If you see lobar consolidation, lobar infiltrate, that's most likely typical for bacterial pneumonia. Okay. Here, what can you see?
Bilateral infiltrates above the mid zones.
Okay, excellent. Okay. If the patient is presenting with respiratory symptoms, fever, cough, malaise, what's the most likely diagnosis? What do you think? Again, it's pneumonia. Okay, again, it's pneumonia. But this type of pneumonia is not typical. Okay, either it's viral because the infiltrate is bilateral, or it's atypical bacterial. Okay, like in case of Mycoplasma, Legionella, they usually not Legionella, not really Legionella. Legionella usually present the lobar ones, but the bilateral viral is the most common one. But if it's bacteria, Mycoplasma, or chlamydia is the most common atypical bacterial causes of the chest X-ray on the right. Okay. There are like 2 types of pneumonia. Okay, typical and non-typical, or typical and atypical pneumonia. Okay, how to differentiate between typical and atypical, or what is the difference between typical and atypical pneumonia? Any answer?
X-ray findings.
X-ray findings. Okay. Other thoughts?
Clinical presentation and chest X-ray.
Clinical presentation. What else?
الجرام ستين cannot detect الاتيبيكال لما أسوي culture.
برافو عليك حصة. True. So the way to differentiate between typical and atypical is by gram stain, not by the clinical picture, neither chest X-ray. Okay, so if the gram stain is positive, this is considered as typical pneumonia. Typical pneumonia, it has its own like list of causative organisms. most common organism among all people who present with picture of pneumonia is pneumococcus. Whatever the situation, whatever the risk factor, whatever the host, whatever the situation, whatever the age. Okay, pneumococcus always is the most common. If I tell you that the patient is elderly, bedridden, and the patient is diabetic and is having a history of upper respiratory last week, and the patient is alcoholic, and the patient dental hygiene is poor, the most common is pneumococcus. Always the most common cause of pneumonia is pneumococcus. Okay, this is the money table. Money table shows that different organisms have different typical scenarios and typical chest X-ray findings and risk factors. Okay, I'll leave it there for you to read it. But as the pneumococcus is the most common cause of typical pneumonia, they typically present with cough with rusty sputum and rigor, fever, shortness of breath. Okay, the typical chest X-ray finding in those people is lobar, as the X-ray we showed just in the last slide. Lobar consolidation is the most common finding. Okay. Moreover, the worst type of bacteria among the typical pneumonia is the Klebsiella pneumonia in terms طبعا of mortality. أسوأ واحد فيهم Klebsiella pneumonia. اوكي ليش؟ لأنه الريسك اوف CRO and ASPL اللي هي طبعا carbapenem resistance organisms والاكستندed spectrum beta lactamase is very high. يعني هذول those kind of patients usually having resistance to most of the antibiotics. That's why the mortality rate among those people is very high. By the way, this table, you should know every single word in there, okay? But due to the time, and I cannot explain every single information in here. This is the second table, shows atypical pneumonia. طبعا احنا قلنا في التيبيكال بس typically احنا we find it in the gram stain, لكن في الاتيبيكال usually gram stain is negative. Okay. What we mean by atypical pneumonia, أحسن طريقة انكم تصنفون فيها الاتيبيكال pneumonia by the age. If the patient is infant, so the chlamydia pneumonia is the most common atypical pneumonia. If the patient is young, so the mycoplasma pneumonia is the most common one. If the patient is elderly, Legionella is the most common one. Okay. طبعا غير البكتيريا we have fungal causes. Okay. And Q fever and psittacosis يعني based على risk factors على ال occupation of the patient. يعني لو patient جاي bird handlers هذا طبعا common exam questions دائما يسألونه في الاختبارات يعني انه patient is bird handlers وكذا وبعدين جاي patient sudden onset of cough fever, weight loss, patient is having like relative bradycardia. اوكي هنا نفكر في اللي هو السيتاكوزس. Okay, great. Managing patient with pneumonia always start with good precaution. What I mean by good precaution, airborne one. Okay. الماسك اللي تلبسونه هنا لازم يكون N95. Why? Because patient who present with community acquired pneumonia could have TB. Okay. You might discover that after a couple of days that the patient is having TB. Okay. بعد شوي احنا بنتكلم عن التي بي فيها 3 stages. Primary one عادة يجون community acquired pneumonia like. Okay. That's why أي patient present with pneumonia ولا pictures حتى clinical picture قبل ما تسوي X-ray قبل ما تشوف أي شيء في الإكس-راي always airborne kind of precaution is the best way to start with. Okay. Managing patient with pneumonia is either طبعا outpatient ولا inpatient, and that's based on the curve 65 score. أنا بنتكلم عن curve 65 score بعد شوية إن شاء الله. curve 65 score يحدد لي إذا البيشنت هذا eligible for outpatient therapy ولا البيشنت هذا should be admitted and receive IV antibiotic. If the case is outpatient, then you ask yourself, is the patient healthy or comorbid? Okay. إذا البيشنت healthy وما أخذ أي antibiotic in the past 3 months, الفيرست لاين عندي دوكسيسايكلين. الفيرست لاين again is doxycycline مو بوجمنتين, doxycycline. okay, because this is a common mistake. Doxycycline, if it's not available, well, the patient is allergic to doxycycline, then amoxicillin is the best option. If the patient is comorbid أو أخذ antibiotic in the past 3 months لكن ما في response, هنا augmentin is the first and the best option. Okay, and the rest of the list برضو عندكم other options. وباي evidence ما في single antibiotic is better than the other. كلهم equally effective. لكن augmentin تعرفين إنه هو موجود available و cost effective and everything. Okay. If the patient is for inpatient therapy, then are you dealing with a patient with community acquired pneumonia? Or are you dealing with patient with severe pneumonia that is enough to admit him to ICU ولا high care unit؟ أو البيشنت هذا عنده health care associated pneumonia. يفرق الموضوع معك في selection of antibiotic. Why؟ لأن الموست common organism يفرق من type to type. إذا كان community acquired pneumonia معناته إحنا قاعدين نتعامل مع الcommon typical bacteria. اوكي، فهنا يصير الاوبشنز، افضل اوبشنز عندنا سيفترايكسون انازيثرومايسين. اوكي، اذا البيشنت is sick enough to be admitted in ICU, then you need triple antibiotics. اوكي، سيفترايكسون وليفوفلوكساسين اند فانكومايسين، كل الثلاثه هذه مع بعض. ليش؟ سيفترايكسون از برود سبيكترم، غطي لي جرام نيجاتيف بوزيتيف وصم يعني كفرج اجينست الانتي سودومونال. ليفوفلوكساسين هذه طبعا از بوست ثيرابي اجينست الانتي سودومونال، هذا المين يعني جول اوف ليفوفلوكساسين. والفانكومايسين عشان موضوع الامار السيء. اوكي، if the case is healthcare associated pneumonia تقريبا نفس التريبل ثيرابي، ولكن you go with more advanced cephalosporin. يعني في السيفير نيمونيا احنا نعطي سيفتراكسون ثيرد جنريشن cephalosporin، لكن في الهيلث كير اسوشيتد نيمونيا نعطي فورث جنريشن cephalosporin. اوكي، it has a better coverage against السودومونس. Here is CAP 65 score. طبعا هي اصلا CAP 65 score is a prognostic one. Okay, it's used for prognosis. ولكن emergency physicians took the advantage of this score to use it as a disposition tool. Okay, and by evidence is a good one. Excellent tool to decide either to admit the patient or discharge. Okay, here is the prediction of 30 days mortality. If the score is more than 4, the mortality rate goes 30 or even more than that. Okay, ولكن as decision to for disposition, if the score is 2 or more, then you should admit the patient. Okay. So the cutoff عندنا تقريبا اللي هو 1. إذا كان سكور أكثر من 1 معناته البيشنت هذا for admission. Okay, last slide in pneumonia هو طبعا aspiration pneumonia. هذه one of the common presentations. أنا أتوقع أنكم تشوفونها في emergency department كثير. وزي ما طبعا احنا as we mentioned earlier انه في there is a difference between pneumonitis and pneumonia. في pneumonitis no indication of antibiotic unless ان السيمتومز هذه جلست اكثر من 2 days او ال patient develops fever. Okay, here هنا you suspect a translocation of bacteria and the patient start to have pneumonia. Okay, if the patient present اصلا وعنده signs and symptoms of genuine pneumonia, if it's community acquired, then augmentin as outpatient. لكن إذا كانت health care associated pneumonia أو إنها dental origin, هنا admission ونعطي broad spectrum antibiotic tazocin with vancomycin. Okay, sorry I said in the last slide, لكن هذا last slide. This is a special type of pneumonia that exclusively affect the patient with HIV. Okay, هذه ال PCP تصير هذه one of the most common and most serious complication of HIV. Okay, something called PCP, pneumocystis pneumonia. A patient usually present with يجون atypical presentation يعني يجون براي كاف يجون exertional dyspnea يكون عندهم weight loss fatigued extreme fatigability and so on. Most sensitive lab marker LDH, however, it's not specific, okay? And the definitive diagnostic method for PCP is bronchoalveolar lavage, okay? This is really important. The classic presentation or the classic X-ray finding in patient with PCP is bat wing sign, okay? Bat wing sign. If you receive a patient who's having HIV and complaining of dry cough, and you do chest X-ray and find this, it's a PCP until proven otherwise. Okay, so this is really important. This is what's so-called bat wing sign. Okay, don't forget this one. Managing patient with PCP, simply start with Bactrim, trimethoprim, sulfamethoxazole, and if the patient is allergic or it's not available, so you go the second line, which is pentamidine. Pentamidine is specific therapy in such case. It comes in two routes, e.g. inhalational, e.g. IV. Okay, ولكن اللي ابغى اوصل لكم اياه as emergency physician, whenever you start pentamidine, start it with slow rate infusion. Okay, why is that? لأنه في common side effects تصير من البنتاميدين. If it's IV, you have to watch out for hypoglycemia or hypotension. Okay, hypoglycemia and hypotension. And if it is inhalational, it is associated with pneumothorax. So pentamidine is a serious medication. You add to that steroid if it's indicated. طيب, what are the indications of giving a steroid? أحتاج الحين أسمع منكم. What are the indications of giving a steroid in PCP?
low arterial oxygen
Okay.
by ABG.
Okay. ممتاز. What else?
low
auto
AA gradient.
saturation auto
Okay.
saturation أقل من 70 في الروم A.
Okay. Okay.
in case of severe يعني moderate to severe أو AA gradient more than 35.
Excellent. FA gradient more than 35. This is one indication. The other indications إذا كان عندي oxygen less than 92%. Okay. Or partial pressure of oxygen. هذه طبعا في ال ABG في الارتيريا blood gas less than 70. هنا نعطي patient steroid to fasten the recovery. Okay. طيب
دكتور
yes please.
عادي ياخد بريك 10 دقايق ونرجع.
ما this is the last two slides بعدين بناخذ 10 دقائق.
اوكي تمام.
Okay, يعطيك العافية. Okay, so now let's talk about ARDS just in two slides. طبعا ARDS is extreme consequence من ال serious lung pathologies. Okay, لها criteria, لها definition, either clinically ولا by image, okay, or by lab. طبعا متى أنا أفكر في ال ARDS؟ إذا كان patient develop new or worsening respiratory symptoms وعنده في ال X-ray bilateral opacities. Add to that, either patient is having evidence of respiratory failure by مثلا blood gas وما عندي clear cause of that respiratory failure. هنا الواحد يبدأ يفكر في ال ARDS. And the ARDS classified, يعني ARDS severity classified based on the something called PF ratio. Okay, classified into mild, moderate and severe. A PF ratio اللي هي partial pressure of oxygen على ال FiO2. وفي لها تشارت، التشارت هذا عادة تحصلونه مع ال RT. If you ask for PF ratio, they know it. Okay. If the PF ratio is less than 300, the disease is considered mild. If it's less than 200, the disease is moderate, and if it's less than 100, this is considered as severe ARDS. Okay. Typical look of chest X-ray of ARDS. Okay. So nasty. Very bad one. Okay. هذه من أسوأ chest X-rays اللي ممكن تشوفونها بحياتكم. Okay. And this is of course mandates ايش؟ intubation. Okay. And such patient هذا يحتاج intubation. لأنه almost there is no room for ventilation. Okay. Suggestive diagnostics. إذا كان عندي partial pressure of oxygen less than 16 ABG. اوكي. لما يكون عندي البلمونري كابيلاري ويدج بريشر less than 18. طبعا وش معناته لما يكون البلمونري كابيلاري ويدج بريشر less than 18؟ معناته الفنتريكلز عندي الفانكشن اوف ذا ventricles is intact. اوكي، معناته ما هي هارت فيلير. باي اذر وورد، اذا كان البلمونري كابيلاري ويدج بريشر هذا more than 18، هنا افكر انها تكون هارت فيلير اكثر من الاي ار دي اس. هذه طبعا من اكثر السيناريوز اللي تلخبطكم كلينيكلي. از ات ترولي ار دي اس ولا هذه تكون هارت فيلير؟ فالوجه بريشر كان هيلب يو. طيب هل هي من الامرجنسي؟ الامرجنسي صعبه جدا. ليش؟ لانه ميجرنج الوجه بريشر نيدز انفيزيف بروسيجر كولد سوان جانس كاثيتر. تحتاج ان سوان جانس كاثيتر inserted to the lung capillaries و you measure that pressure. So this is nothing, يعني it's not something easy to do in the emergency setting. Okay. The most common cause of ARDS is sepsis. Okay, and the best way to manage patient with ARDS is intubating them. Okay, intubating them and following the lung protective strategy. Okay, ما هي lung protective strategy؟ اللي هي في certain set of parameters في الميكانيكال ventilator. You have to memorize it. You have to apply it in every single patient present with ARDS. Okay. Just set that machine to assist control. Go. نعم. Go with low tidal volume. Okay, 6 to 8 ml per ideal body weight. Respiratory rate should be low as 12. يعني 12 to 14 is the best rate. IE ratio 1 to 2. PEEP lowest possible. حاول تخلون البيب أقل شيء ممكن. And fire 200%. طبعا واحد يجي يسأل طب what is the goal of lung protective strategy؟ ليش احنا نمشي على النمبرز هذه؟ The overall aim من موضوع lung protective strategy من اسمها lung protective. So you do something to protect the lung. طيب protect the lung from what? From something called barotrauma. Okay, barotrauma اللي هي iatrogenic pneumothorax. Okay, ان احنا ما نحاول whenever we intubate the patient نحاول قد ما نقدر نقلل ال chance of alveolar overinflation، لأن alveolar overinflation هذه تسوي لنا باروتروما. وإذا حصل عندك ARDS مع نيموثوركس، أنا أعتقد هذا أسوأ كومبانيشن ممكن يرد يعني يمر على أي emergency physician ولا أي سي physician. هذا nightmare يعتبر. Okay. Great. So now is the time to take like 10 minutes break for prayer. If you have any questions so far, anything to know, please let me know. ترى معليش أنا ما أشوف chat box، please open the mic and speak.
How about the pneumonia severity index in case of pneumonia?
Pneumonia severity index is excellent tool to stratify the risk of pneumonia. Okay, it is more sensitive than CARE 65. However, pneumonia severity index it has its own limitation from the emergency point of view. That pneumonia severity index has a lot of information that you have to obtain before you calculate the final score. Okay, most أو ما some, let's say some of the parameters اللي موجودة في النيمونيا severity score you cannot obtain it in 4 hours window في emergency department. بعضها تحتاجها يوم، بعضها يومين عشان أنت you can calculate a pneumonia severity index. فمشكلتها أنها طويلة وما هي مرة practical in the emergency department. That's why CARE 65 you can do it بس من اللابس، بس تطلع لي اليوريا كم and you can calculate CARE 65. Is that clear؟ طبعا في طبعا عندنا سكورز كثيره، مو بس نيموني سيفيريتي اندكس و اي ار دي اس. في عندنا سمارت كوب برضو من السكورز اللي انا اعتقد سون ممكن حتدخل في كتبنا. وهذه سمارت كوب يعني تساعدنا كثير في الديسيجن اوف انتوبيشن النيمونيا بيشنت. sometimes يعني الناس اللي عندهم experience في emergency practice وأكيد شافوا patient with pneumonia and they look sick. Okay, ويحتارون shall I intubate that patient or not. فسمارت كوب is the key. Okay. ففي other scores يعني scores كثيرة لكن by literature by evidence curve 65 is the best to follow في emergency. Any other question? You all good؟ ولا
يا
نمتم؟
دكتور
خاف
no
انكم
we're
نمتم.
good. لا
آه.
معك، بس نصلي إن شاء الله 10 دقايق ونرجع كذا،
طيب
نرجع على 6:30، هي 36 بالضبط.
توكلنا على الله. يلا
أوكي خلاص على التايمر. يلا.
بإذن الله.
Yes, doctor.
Okay, great. Finally, I managed موضوع chat box, so now I can see it, alhamdulillah. So feel free to write anything in the chat box or open the mic at any time. Okay, Bismillah. So now we'll start talk about اللي هو tuberculosis. Okay. Tuberculosis, the most concerning sign or presentation in patient with TB is massive hemoptysis. Again, as massive hemoptysis could lead to asphyxiation. So this is, again, is a nightmare for emergency physician. Okay. Most common cause of TB is Mycobacterium tuberculosis. Okay. And the way of transmission is droplets plus airborne. So the best way to take precaution is airborne. Okay. N95. The strongest risk factor for tuberculosis is immigrant from high prevalence places. Okay, those who came from high prevalence countries of TB is the strongest and the worst risk factor for any spread of TB. Okay. Furthermore, the most common cause of death among HIV is TB. Okay, so there is a clear and strong association between HIV and TB. There are like three types, or let's say three stages of TB: primary, latent, and reactivation. Okay, with reactivation being the most common one. Primary, when the patient presents with flu-like symptoms. Okay, and latent, when the patient stays asymptomatic for years. Okay, and reactivation, when the patient start to have this pulmonary complaint and even extrapulmonary manifestations. Okay, the most common extrapulmonary manifestation in patient with TB is something called scrofula. Scrofula is tuberculous lymphadenitis. Okay, as you can see in this picture here, it is kind of unilateral, swollen, non-tender kind of skin lesion over the lymph nodes. And if it's left untreated, it might result in purulent kind of skin lesions. Okay, وتصير فيها superimpose infection, and this will worsen the skin lesion. Diagnosing patient with TB starts with doing this PPD test. Okay, PPD stands for purified protein derivative, injecting like 0.1 ml of this substance intracutaneously, and you leave the patient for like 2 to 3 days, then you measure the induration. I would say it one more time, induration. You measure the induration, not the erythema. Okay, not the surrounding erythema. Only the induration, the raised borders of the skin. And it is considered positive if the induration is more than 5 ml, but in patient with HIV, or if the patient gave you clear history of contact with TB patients, and it's considered positive if more than 10 millimeter or 1 centimeter, if the patient is immunocompromised or healthcare provider. Okay, and it's considered positive if the induration is more than 15 millimeter in all population. Okay, in all population. Okay. The second test is sputum sample. Okay, either by smear, culture, or PCR. طبعا كلهم هذولي the most specific ones. Okay, the way of collecting sputum sample, you collect 3 morning samples in 3 consecutive days. Okay, وهذه عادة في الادult facilitated by nebulizer. Okay, give the patient nibs to facilitate the sampling. The third test is something called quantiferon. Quantiferon is the most sensitive one. لكن إيش مشكلة الكوانتيفيرون؟ الكوانتيفيرون مشكلته الافيلابيلتي، مشكلته الكوستي، غالي جدا. وغير إنه غالي، الكوانتيفيرون cannot differentiate between الactive and latent infection. ما يقدر يفرق لي بين الاكتيف والليتنت تي بي، اوكي، ولا يقدر يفرق لي بين المايكوبكتيريال تي بي او الاذر تايب اوف مايكوبكتيريا. it is sensitive but not specific. Chest X-ray في primary TB the most common finding is normal X-ray. Okay. أو patient present يقدر يجينا signs of community acquired pneumonia as we mentioned earlier. And the latent TB gone complex as a typical finding. طبعا gone complex وش معناتها؟ معناتها إنه الهايلر lymph node get calcified. Okay. وغالبا stays there for years or even for life. Reactivation of TB هذه where the patient start to complain of genuine pulmonary manifestations. يبدأ معاهم الtypical findings اللي نعرفها اللي هي الcavitation. Okay. Let's take it one by one. And this chest X-ray, what do you see? What do you think?
Parahailer opacity.
سمعت opacity. صحيح. What else?
Pleural effusion.
On the left side, okay.
Hilar adenopathy.
Okay.
Prominent vascular marking.
Excellent. So it's like finding of early pneumonia. Is that true? يعني تحسون non-specific finding that be most likely linked to the infectious cause. صح? Do you agree?
Yes.
Okay, great. This is a real patient who was labeled as TB لكن 3 days after. Okay, the chest X-ray was done in the emergency department, and the patient was diagnosed as having pneumonia. And due to the age of the patient, they admit the patient with a course of IV antibiotic. ولكن 2 days after لقوا إن البيشنت هذا عنده إيش positive TB. طيب, how about this chest X-ray? What can you see here?
Large
The black arrow speaks.
lymph node.
Okay, gone complex. Excellent. Gone complex as you see here في تقريبا في الرايت هايلم. طبعا عادة يكون عندنا lymph nodes هنا. lymph nodes هذه قد calcified, فإذا جت calcified تبين لنا في الإكس راي as gone complex. Okay. How about this? What type of TB? If I tell you this is TB patient, what type of TB?
Cavitary TB.
Okay, cavitary. Reactivated TB. Excellent. Excellent. So there is obvious here cavitation, okay, in the right upper loop. طبعا التي بي تحب الأماكن اللي فيها high oxygen. So cavitation typically happens in the lungs areas with highest amount of oxygen. Okay. ولما أحد يسألكم where are the highest areas of oxygen in the lung؟ في الأبيسس، فوق في الأبيسس، وفي الposterior upper loop، ورا في posterior region of the upper loops، وفي superior regions of the lower ones. Okay. superior of the lower lobes. هذه أكثر أماكن فيها oxygen where the TB lost to form. Okay, managing patient with TB, basically from the emergency, all what you need to know and you do is good precaution, and you notify the whole team, okay, and you start TB testing if you raise suspicion of TB, okay. If the picture initial goes with community acquired pneumonia, so you manage as community acquired pneumonia, okay. Anti-TB drugs should not be initiated by the emergency physician unless it's coordinated with the ID physician, okay. And the regimen is RIPE. I think you all know it. And here are the common side effects of رايب طبعا اللي هي ريفامبين وزنازايد ولا بيرزيناميد وثامبيتول. each of which has its own like common side effects. This red colored letters could help you to link things and remember it. Okay. In case of latent TB, isoniazid course should be extended to up to 9 months. لكن only isoniazid. Okay. only isoniazid. طبعا في موضوع هنا مهم جدا انه نعرف ليش what's the idea beyond combining several anti-TBs. ليش ما انا الواحد يجيني active TB I only just start him على ريفامبين ولا ريفامبين انزلازايد and that's it. ليش ابدا على الفور medications؟ احد يعرف؟
To initiate rapid killing of bacteria.
Good thought. However, not really. طبعا الريزن أكثر شيء to overcome the resistance. Okay. المشكلة التي بي الانسيدنس of resistance للأنتي تي بي is very high. That's why combining all these medications together in the given period of time. طبعا في common scenarios. خلينا نقول exam point of view. Clinically, it's very important to know, however, it's very rare. Something called paradoxical reaction. Okay. What's so called طبعا immune reconstitution syndrome. هذه فكرتها ان patient clinical presentation getting worse after starting an anti-TB. Okay. After they start anti-TB, they start to have this worsening clinical presentation. This is normal. Just supportive management and resume the management. Okay, what can you see here? This is a very bad subtype of TB.
Retinal TB.
Come again?
Retinal TB, the picture on the right.
Miliary TB.
Miliary TB. Okay, excellent. Yes, good. So miliary TB. Miliary TB هذه the most extensive and bad version of TB. Okay. هذه when the TB goes hematogenous. لما يصير الموضوع hematogenous, it goes beyond, it spread all over, it goes to the chest, to the eyes. فتبدأ تسوي لنا هذه specific and pathognomonic signs للTB, miliary TB. Okay. In the chest زي ما انتم شايفين هنا في diffuse nodular lesions في both lungs. هذه يسمونها seeds like appearance. الساين هذه اسمها seeds like appearance. هذه so characteristic miliary TB. Okay. And the right on your right side there is like a picture of a fundoscopic finding. Okay. بتشوفونها كذا scattered white patchy lesions. هذه يسمونها eye choroidal tubercles. Okay. هذه very pathognomonic لموضوع الملياري تي بي. وش الكونسيرن هنا؟ The biggest concern is TB meningitis. Okay, TB meningitis due to TB. It's very important. And if you find such finding, so you should proceed with LP, confirm the diagnosis, and you should start the anti-TB management in timely manner with dexamethasone. طبعا هنا steroid is very important لأنه يقلل لنا mortality. Okay, dexamethasone is very important in TB meningitis. Okay. إضافة. You all good?
I have a question, Doctor.
Please.
Regarding the starting medications of TB. بس in case two cases لو كان for example miliary TB or يعني you're trying to admit or in case close contact of مثلا healthcare worker, do you get to start anti-TB medication or you refer them والspecialty they can refer they can start?
Good question دكتور عبد الله. طبعا هنا يعني هي depends on the case. يعني إذا كان الكيس TB meningitis you manage as meningitis so time is brain. فهنا تحتاج إنه you start anti-TB in the emergency department, you call the ID, you coordinate in the emergency department and start right away. هذه ليش؟ لأنها meningitis صح ولا لا؟ كل دقيقة تمر it counts. فهنا يختلف الموضوع. لكن إذا patient جاي healthcare provider وعنده contact with TB and you suspect TB and the patient looks well and fine, هنا start اللي هو investigating and confirming the diagnosis first and you start ال anti-TB according to the result. يعني either to start or not، يعني based إذا طلعت لك positive TB يعني you start. والحقيقة مو أنت اللي start، يعني إذا كان healthcare provider أنت you just guide you start طبعا investigation and you guide for management as outpatient مع البرايمري هيلث كير ولا staff clinic. اوكي واضح دكتور عبد الله؟
Sure, thank you.
You're welcome. Any other question? Okay, well, now moving to the pneumothorax. Okay, pneumothorax is very important, very common. I believe إنه الآن أبغى أسمع منكم، جاء دوركم، تكلمت كثير أنا اليوم، فأحتاج أسمع منكم الآن. أوكي. Pneumothorax simply it's air between the or air in the pleural space between the visceral and parietal pleura. This is easy question, easy answer, logic. Okay. لكن عندنا two types of pneumothorax. Okay. Either primary or secondary. Okay. Primary pneumothorax لما ما يكون عندي lung disease، ما في underlying lung pathology. Okay. وكذلك you classify primary into spontaneous or traumatic. هذه primary. Secondary to what? Secondary to lung disease. Most commonly COPD. Okay. فعندنا هذه two types of pneumothorax. Risk factors spontaneous pneumothorax تعرفونها، يعني thin, tall, smoker, male, plus minus Marfan syndrome، هذه كلها risk factors of spontaneous. Can anyone tell me what are the classic triad of pneumothorax? Or tension pneumothorax, sorry. Classic triad of tension pneumothorax.
Hypotension, GVB increased أو absent breath sound.
Absent breath sound, excellent, good. Okay, in case of pneumothorax, the symptoms can start with simply dyspnea, chest pain, or should go extreme to up to tension, where the patient starts to have this decreased breath sound in one side or both sides. طبعا لأن tension pneumothorax ممكن تكون bilateral. Tracheal deviation, hypotension, hyperresonance and percussion, distended JVP. Okay. لكن المهم جدا to differentiate between the tension and non-tension pneumothorax الtypical أو classic triad اللي قال لنا عليها الدكتور. Most common ECG abnormality is sinus tachycardia. I think that's obvious. Okay. How to diagnose patient with tension pneumothorax? Yeah. This question is for you, Dr. Lama.
X-ray?
Clinical and chest X-ray.
Clinical and chest X-ray.
If it's tension pneumothorax, clinically. If pneumothorax, by ultrasound.
Okay, excellent. So tension pneumothorax is still clinical diagnosis. Okay. Why clinical diagnosis? ليش ما معها X-ray? And X-ray takes time. And tension pneumothorax patient wouldn't give you time to stay alive. Okay. فtension pneumothorax it's a clinical diagnosis by giving اللي هو موضوع 3 classic triad based عليها you start your needed decompression. Okay, it's very important. طيب non-tension pneumothorax نتكلم عن pneumothorax اللي ما هي tension. How to diagnose it?
Ultrasound.
Okay, ultrasound. What else?
Chest X-ray.
Chest X-ray. ممتاز.
CT.
طيب ممتاز. CT. What is the best?
CT.
CT is the most accurate one. Excellent. طيب, is it indicated in all patients? No. Unless في certain indications, يعني مثلا trauma patient. Okay, and nothing in chest X-ray and ultrasound. At that time ممكن نسوي CT عشان CT هي most accurate. Can detect smallest area of pneumothorax, something called occult pneumothorax. Okay, لكن CT is not always indicated. What always indicated is chest X-ray and ultrasound. Which one is better? Which one is more accurate, more sensitive, more specific?
Ultrasound.
Excellent. Ultrasound. What are the findings of pneumothorax in ultrasound?
absent of sliding
Excellent. ممتاز.
and
هذه
barcode
most specific ولا most sensitive?
most specific.
Absent of
لا.
sliding.
sensitive.
Most sensitive. And the
Yes.
most specific?
barcode sign اللي هي مود.
Okay. Okay.
في
Okay.
حاجة دكتور بدر اسمها لانج بوينت.
Excellent. Lung point. Lung point. Okay. Lung point is the most specific sign. Okay. While absent sliding is the most sensitive. Bravo. MashaAllah. طيب. Chest X-ray. What are the specific findings in chest X-ray? Simple. بس اعمل ultrasound.
Deviation of the trachea.
Deviation of the trachea extension. What else?
Lung collapse.
Lung collapse. Okay. Deep sulcal sign. Excellent, Dr. Zainab. Okay. This is one of the specific signs. ممتاز. Excellent. Excellent. Well said. So chest X-ray and the PA view نشوف loss of lung marking. يعني اللي انتم قلتوا عليها collapse. Okay. And in the supine view, deep sulcal sign is one of the most specific signs of pneumothorax on chest X-ray. Okay. Regarding loss of lung marking, طبعا في two areas نشوفها to judge. Okay. ومهم جدا to classify size of pneumothorax وبناء عليها we decide our management. في American rule وفي British rule. Okay. هذه التو areas. الامريكان تشوف لان الايبكس كم عندنا المسافة من الكولابسد lung at the apex till the cupula. cupula يعني معناتها most apical margin of the thoracic cage. وبنشوفها بعد شوي. Okay, if it's more than 3 centimeter مسافة الكولابس lung أو pneumothorax, here we consider it positive, and large pneumothorax هنا يحتاج لها serious management. Okay, in the British rule هنا نشوف level of hilum. Okay, ونقيس من margin of collapsed lung till the edge of thoracic cage. If it's more than 2 centimeter pneumothorax هنا نعتبرها large pneumothorax وهنا نحتاج إن إيش؟ أن نبدأ السيريس مانجمنت حقتنا. Okay. Ultrasound loss of sliding sign. طبعا loss of sliding اللي هي absent sliding طبعا. والإمود باركود ساين. طبعا هذه نشوفها في حالة أن يكون في عندنا clear lung point توضح لنا أكثر. طبعا هنا this picture demonstrates اللي هو موضوع أو illustrates موضوع النورمال lung من النيوموثوركس lung with pneumothorax. طيب في النورمال circumstances as you can see here طبعا يكون عندنا normal movement between a parietal والvisceral مع البريث. اوكي يسمونها shimmering movement. فيبين لنا يبين لنا زي الهايبر اكويك structure that moves back and forth. وبنشوفها بعد شوي في كليب. once you convert the view to M mode بتشوفون عندنا حاجة اسمها seashore sign وهذه normal. okay, seashore sign normal. In the right half of the image تشوفون النيموثوركس. pneumothorax يصير في absent of sliding. That movement between parietal والvisceral pleura will be absent. okay, يتنفس المريض ما في أي motion. once انكم انتم يست الماشين على الام مود تشوفون تطلع لكم اللي هي الساين هذه نسميها ايش؟ ايش نسميها الساين هذه في الام مود؟ what do you call it؟ مكتوبة
barcode.
barcode sign. excellent. great. okay. what do you think about this chest X-ray? what can you see here?
hyperinflated chest.
ممتاز. what else?
Lung collapse.
Right lung collapse.
Which lung? You have to be
Right lung.
specific.
Right lung.
Right lung. Okay. دكتورة ريماس, you cannot judge upon deep sulcus sign with PA view. تحتاجينها تكون supine view لازم عشان أبدأ أشوف الديب sulcus sign due to the translucency. Okay, effect. يبين معانا الديب sulcus sign. بنشوفها بعد شوي. طيب. لكن in this lung, what I can see, loss of lung marking. Okay. نشوف الأمريكان والبريتش رول. أمريكان هذه تشوفون من ال edge of the lung apex till the edge of cupula. هذه يسمونها cupula. فعندك المسافة if it's more than 3 centimeter, which is the case, هذه more than 3 centimeter, هنا نعتبرها large pneumothorax. Okay, large pneumothorax. طيب, the other rule British one, level of hilum نقيس برضو من اللنج ماركينج إلى الإدج حق الثوراسيك cage if it's more than 2, so this is large pneumothorax. Is it clear? واضحة؟
Yes.
Okay, excellent. دكتورة ريماس, what do you think about this? هذه طبعا it's a supine chest X-ray. What can you see here? Deep sulcus, excellent. Right or left? Right or left?
Right.
Right, excellent. So you can see the translucent structure extend down even at the level of liver. Okay. So this is deep sulcus sign, and زي ما اتفقنا ال deep sulcus sign ترى تعتبر one of the most specific, however it's rare. Okay. طيب خلينا نشوف الالتراساوند. we're gonna see the normal one عشان نشوف ايش معنى sliding والabsent sliding. Let's start with the normal one. Okay. طيب هنا عشان الوقت. Look at this.
The visceral pleural against the parietal pleural.
Look at this. Do you see the shimmering artifact? Did you see it? تشوفون الموفمنت الهايبر echoic structure. This is normal. هذه sliding. Okay, this is sliding. Okay. في أحد ما انتبه لها؟ ما أحد شافها؟ ولا واضحة؟ What do you think?
واضحة دكتور.
واضحة. Okay, excellent. إذا اللي ما هي واضحة له بس يقول لي عشان أرجع أشرحها له من جديد. Okay.
ممكن تعيدها دكتور؟
نعم تفضل.
كنت تعيدها؟
أبشر. هذه look at this. شغال عندك؟
ايه شغال.
Great. You see the movement?
ايوه.
Did you see it ولا لا؟
اللي عليها لون اخضر.
هنا. You see it؟ هذه. بتشوف البوينتر ولا ما تشوفه عندي؟
ايوه اشوف واضح.
أي هذا هو. This movement. This movement with respiration is considered normal. Okay, this is considered normal. Okay. خلينا نشوف الابنورمال one. هذا patient with pneumothorax. See. عندنا هذا rib. Okay, and this is another rib. البروب هنا. Okay, between two ribs. And it shows هذه البلورا. Okay, it shows ايش؟ وش نشوف؟ في sliding ما في sliding؟ في sliding ولا ما في؟
sliding ما في.
Yeah, absent of sliding. Exactly. So this is the most sensitive sonographic sign for pneumothorax. Okay, perfect. Okay, now is the time to manage a patient with pneumothorax. Okay. زي ما اتفقنا هي تعتمد على size of pneumothorax. If the size is small, What I mean by small يعني عندنا per the American rule less than 3 centimeter, per British less than 2 centimeter. والبيشنت is asymptomatic. ترى هذا شرط أساسي إن البيشنت يكون asymptomatic، لأنه once يكون symptomatic معناته لازم هنا أنا أعتبرها هنا كأنها large pneumothorax ولازم أسوي chest tube. Okay. In this case, I mean in small primary pneumothorax, the best way to deal with those patients انك تحطه على oxygen mask ويوري اسسهم وتسوي له X-ray every 3 to 4 hours. You repeat the X-ray وتشوف the course of the disease. Is the pneumothorax improving ولا worsening? Okay. In case of improving تكمل معاه إلى ما يصير full recall of the lung ولا full expansion of the lung. بعدها تخرج المريض with close follow-up. If the patient is worsening with a serial chest X-rays at that time طبعا تعامله كأنها إيش large pneumothorax where chest tube is indicated. Okay. طبعا other line عندنا other than observation small size catheter aspiration. طبعا small size catheter aspiration هي technique rarely طبعا being done in emergency departments عندنا في السعودية. However, it is less invasive. It's a quick kind of procedure. The success rate is very high. Okay. Try to look at this procedure في ال trusted resources وشوفوا كيف يسوي procedure. It's very simple. All what you need is a 3-way stopcock وتحتاجون ال 20 cc syringe وتقريبا 16 gauge needle. That's all what you need. Okay. You anesthetize the area and you insert the needle with gentle aspiration. It works. It works. Okay. This is in case of small primary pneumothorax. هذه عندنا line of management. In case of small but secondary pneumothorax. ايش يعني small secondary؟ secondary زي ما اتفقنا انه في البيشنت عنده underlying lung disease وصار عنده small pneumothorax. اوكي. هنا يحتاج البيشنت ايش؟ chest tube او طبعا catheter aspiration. In case of large pneumothorax هنا دائما نحتاج ايش؟ chest tube. اذا كانت large زي ما اتفقنا more than 3 cm American more than 2 cm British هنا نحتاج نحط chest tube. in case of tension pneumothorax طبعا وش نسوي في الكيس in case of tension pneumothorax? What is the first thing to do?
Needle aspiration. Second.
And what? ممتاز. وين؟
Mid-clavicular line.
Mid-clavicular line وين exactly? In which space?
Second.
برافو عليك. برافو عليك.
Just a tube and fourth to fifth.
Excellent. Excellent. Then followed by the definitive management which is chest tube. Chest tube وين يكون؟
Fourth to fifth.
أيوه.
Mid-axillary line.
أيوه. This is the most common mistake I hear. يعني in the past 10 years اللي دائما أسمع الناس تغلط في وأنا واحد منكم. Okay. I was thinking إنه in mid axillary line while the true answer is من يعلمني true answer؟
Anterior axillary.
Anterior axillary. Excellent. ممتاز. What's the size of needle؟ يعني if you want to do needle decompression what size of needle؟ Any clue؟
Ideally يكون 14 gauge.
14. ممتاز ممتاز دكتور محمد. ممتاز علي. Excellent. 14. طيب طبعا chest tube it comes in different sizes. Okay. ولكن أفضل طريقة أن هي based على التايب of pneumothorax. If it's primary أفضل شيء إنكم تستخدمون 8 to 14 French. Okay. If it's tension 14 to 16 French. Okay. And if it's secondary pneumothorax use smaller size tubes يعني 20 to 28. If the patient is intubated you use 28 French. Okay. I hope that's clear. Okay. Any question? Any question? And the pneumothorax part. All clear?
And do we need to discharge him with a follow-up in 48 hours or يعني or if they're symptomatic to come back to
أي قصدك أي patient أي نوع؟
السمول اللي less than 2.5 cm or less than 3.
أيوة. قصدك إن patient is you
regarding
observe
should
it.
we repeat the X-ray in 48 hour or we don't need to if they are asymptomatic?
As a rule ما في rule after 48
Okay,
hours.
sure.
أنت الدكتور if you want to discharge the patient you discharge the patient إذا صار عندك full expansion after period of time. يعني ممكن البيشنت هذا بعد 3 hours يصير عنده full expansion. شفناها هذه حصلت قبل كذا. اوكي وصار البيشنت totally asymptomatic وهابي وكذا. هذا البيشنت ممكن تعطيه appointment within 2 weeks وclear instruction طبعا انه to come back لما يكون البيشنت ديفلوب اللي هو 1 2 3 symptoms حقت النيموثوركس. اوكي لكن انه رول افتر 2 days ولا 3 days ما فيها. هي انك انت تعيد التشست اكس راي. طبعا هي ما فيها قول ثابت ولكن في بعضهم every 3 hours بعضهم 6 hours بعضهم 5 hours بعضهم 4 hours based on the patient's condition يعني والpatient's subjectivity. يعني البيشنت بعد ساعتين قال لك انا والله احس اني تحسنت مره. This is the time to do chest X-ray to make sure that the lung is fully expanded. لكن patient جالس 4 5 ساعات يقول لك يا اخي انا قاعد نفس الالم عندي ما راح ولا البيشنت ولا البين از worsening وكذا. هنا you continue المانجمنت حقك او even ممكن انك تطلب chest X-ray وتشوف if the size is worsening. هنا تروح وتسوي لنا اللي هو عاد الكاثيتر aspiration ولا يعني you go with more advanced method of therapy. واضحة دكتور؟
يعطيك العافية.
الله يعافيك. Other questions? Okay. Now to the 7th outline, which is asthma. Again, asthma is one of the common and serious pulmonology emergencies. Okay. Asthma is a reversible kind of disease. And the most common cause of exacerbation is viral upper respiratory tract infection. Okay, this is the most common well-known factor that exacerbate asthma. This table shows or this box shows اللي هو risk factors of death from asthma. طبعا هذه table is very important. Very important. You ask every single patient who present with moderate to severe exacerbation, as this make difference in managing such kind of patients. Okay. يفرق الموضوع هنا. مهم جدا انك you ask the patients about how many canisters been utilized in the past month. مثلا كم مرة تنومت في آخر سنة إلى آخره. هل في عندك have you ever been admitted into ICU. هذه برضو من الأشياء المهمة جدا. certain questions could give you a clue about how severe is the disease. Whatever is the look of the patient. ترى الأزمة patient أحيانا يكونوا looks well لكن إنه inside they are so serious and they so in so hectic situation. Always ask about risk factors of death and يعني at best you should write it down. يعني إذا كنت مرة أسطوري أنا أشوف إنك أنت تكتبها في الدوكيومنتيشن كذا تصير أنت يعني فاهم. Okay, as emergency physician, this is really important. وطبعا if you find out any risk factor for death, this is per se an indication for admission. Okay, diagnosing patient with asthma. أحد يقدر يقول لي what is the best assessment tool for asthma؟
الطوارئ دكتور.
أي نعم.
peak flow.
ممتاز. peak expiratory flow rate. Okay, أو flowmetry. Excellent. Spirometry. Okay. هلا وفاء. Excellent. Good. So peak expiratory flow rate is the best assessing and reassessing tool in the emergency department. Okay. And طبعا بالpeak expiratory flow rate هنا أنت you classify severity of the case and based on that again it guides your management. Chest X-ray only indicated إذا patient جاي ب associated signs and symptoms with asthma. Okay, patient asthma usually present with shortness of breath, plus minus dry cough. I understand that. Like if the patient presents with shortness of breath, wheezy chest, audible wheeze even, and the patient is having productive cough with yellowish sputum. At this time, chest X-ray is indicated to rule out إيش؟ إنه ممكن يكون عندي chest infection that exacerbates his asthma. So chest X-ray, you shouldn't do it unless it's indicated. How about blood gas? What do you think? Shall we order blood gas in all patients present with asthma exacerbation? Hmm? اوكي
عادي أجاوب؟
اتفضلي اكيد.
Maybe only if indicated to put him in CPAP or BiPAP we order ABG.
Okay. I would count it. Thank you. This is a good answer, by the way. Other. Okay.
To determine the severity.
تفضل دكتور.
To determine the severity, because there's no difference between ABG or VBG.
Okay. Okay. Blood gas in asthmatic patient is not indicated all the time. Okay. Why is that? لأنه most of asthmatic patients VBG result will show respiratory alkalosis and that's expected. Okay, respiratory alkalosis لأن البيشنت يكون hyperventilating صح ولا لا؟ And this finding per se does not guide your management ولا حتى بتغير لك شيء في management. The treatment remains the same. Okay, your management will be the same. الإشكالية من blood gas especially in early asthma attack إنه fatigability ممكن develops والventilation fails. okay. ولكن هذه تصير over time. فاللي يحصل الآن إنه single VBG at early stage هذه ممكن تعطيك انطباع خلينا نقول خاطئ. falsely reassure you as a clinician يا جماعة. اوكي يعني patient جاي بأزمة في early stage طلبت له blood gas بيطلع respiratory alkalosis. so what? This is expected في early stage pathophysiology point of view. أنا متوقع إن يكون في respiratory alkalosis ولكن patient might have a sign of impending respiratory failure that is not reflected in the VPG في الستيج هذه. الساينز اوف impending respiratory failure ترى ما تطلع لك على طول. البيشنت كلينيكلي تلقاه سك وهو فعليا is having high CO2 in his blood لكن ما تطلع في الفي بي جي على طول. it takes time. That's why single VBG في البداية ممكن تعطيك falsely reassuring you. Okay, it might falsely reassuring you as a physician. That's why blood gas is indicated في حالتين فقط. أحد يقدر يقول لي؟ في two indications لا ثالث لهم.
Life-threatening or status asthmaticus.
نعم.
As case of life-threatening asthma or status as
ممتاز يعني البيشنت بدأ يصير عنده signs of respiratory failure. Excellent. This is an indication. What other indication? إذا البيشنت unable to do إيش؟
respiratory rate low ممكن status.
Yeah, if the patient cannot perform peak expiratory flow rate. He is sick enough not doing that. أول نفس الجهاز spirometry is not available in your department. فهذه two indications of doing blood gas. Otherwise, please refrain. Okay, بيعطيك false impression على الكيس. Okay. This table طبعا shows the severity of asthma. طبعا it could be mild, moderate, severe ولا life threatening. Okay. Classifying the severity of asthma is based on the clinical picture as well as the peak expiratory flow rate. طبعا the best method to classify severity is the peak expiratory flow rate. طبعا the column in the middle. Okay. هذا هو أهم شيء. إذا البيك expiratory flow rate أكثر من 70% من predicted value, this is considered mild. Okay. وهذا can be managed by MDI. الكانستر نفسها الفنترين كانستر can manage the patient. لكن if the patient start to have this moderate kind of asthma, peak expiratory flow rate typically يكون من 40 to 69%. Okay, and we consider it severe لما peak expiratory flow rate less than 40% من predicted value للpatient. Okay, ويعتبر life threatening إذا كان peak expiratory flow rate less than 25%. I don't think life threatening asthma attack patient will allow you to do peak expiratory flow rate. They will be unable to perform the test أصلا. It would be very difficult to measure it. In such case, definitely life-threatening asthma بتبدأ تبين عليهم الساينز of respiratory failure. In such case, you manage a patient as life-threatening asthma. طيب, let's discuss the management of asthma exacerbation. أبغى أسمع منكم الآن. In case of mild to moderate asthma attack, how would you manage patients? What do you think?
Nebulization, Ventolin, Atrovent, back to back, 3 times.
Okay, Ventolin. Okay.
Give him oxygen first.
Okay, what's the target? What's the target?
More than 92.
More than 92, excellent. What other than oxygen? دكتور قال لنا Ventolin, what do you think? Do you agree with Ventolin? Okay.
I will give him short acting.
Okay, excellent, excellent. Let's assume that the patient is responding well للVentolin, and now he's totally asymptomatic and the chest is clear. How do you manage?
You can discharge him.
On
also Ventolin, Q6 hourly, PR. Yeah.
Okay, what else? What other than Ventolin? Okay, الدكتور علي قال لنا steroid.
Case of moderate.
Okay. Would you give him oral steroid ولا IV steroid before discharge ولا IM steroid؟ ايش رايك دكتور علي؟ Both fine.
Both are
fine. So تقدر تعطي IV, IM ولا PO. What is the best? As is this patient is doing fine, is a mild or a moderate case, who's totally improved, ready to go home. So oral steroid is the way. Okay, excellent. Hala. How about severe asthma exacerbation? How would you manage? How would you manage a patient with severe asthma exacerbation?
Short-acting and anticholinergic. Plus steroid.
Again دكتور ما سمعتك معلش دكتور عبد الله.
Short-acting الفنتولين.
Okay, Ventolin.
والاتروفنت الانتيكولينرجيك.
Excellent.
Plus oxygen وستيرويد.
برافو عليك برافو عليك.
VR equal.
Excellent. طيب يعني الفرق الآن في السيفير اتروفنت صح؟ اللي هو الانتي كولينرجيك ثيرابي. ويوجد الاوردر معروف 3 باك تو باك فنترين اتروفنت صح ولا لا؟ and you consider طبعا هنا السيفير كيسز ينقسمون إلى قسمين. patient totally improved and you can discharge them وتعاملوا زي المايلد to moderate PO steroid أو patient getting worse يعني أعطيته 3 back to back and the patient's condition is getting worse. What you will do?
You will consider intubation.
You will before intubation طلال.
Magnesium sulfate. Give him
before
fluid.
magnesium sulfate. Something new in the literature.
You can give epinephrine.
Before epinephrine, the evidence of giving epinephrine asthma patient still ترى weak. It works, yes, لكنه still weak. Okay, so BiPAP ممتاز ضيف. So BiPAP is very important to keep it in mind. If the patient is getting worse, not improving, having severe asthma exacerbation, BiPAP improved إيش؟ Does it improve mortality? Does BiPAP improve mortality in asthma exacerbation ولا لا؟ Chat box. Yes. طيب yes okay ممتاز طيب good. There is no solid evidence in regard of mortality benefit من البايباب في الأزمة. Unlike COPD. البايباب in COPD patient yes decrease mortality but in asthma لا لكن يقلل لنا need of intubation. مضبوط طيب okay and decrease the need of hospitalization, decrease the need of ICU admission. فالبايباب could be a definitive management ولا could be bridging management للintubation. فهنا مع البايباب بيبدأ يبين لنا البيشنت is improving ولا getting worse again. If the patient on BiPAP improving, alhamdulillah, so we give him like area of watchful waiting or reassessment. If the patient on BiPAP and getting worse, this is the time we label him as impending respiratory arrest and we manage him by Talal. What do you think? Patient is not improving with BiPAP. وش نسوي بعدها؟
consider advanced intubation.
intubation. وطبعا intubation comes in a package وش معاه اشياء ثانيه غير الانتوبيشن وبعضكم قالها قبل شويه. intubation
pre-medication يعني
نعطي
magnesium sulfate.
excellent دكتور عبد الله
or
magnesium
ketamine.
sulfate ممتاز. what else? steroid. would you give steroid ولا لا هنا؟
of course
yes.
okay. what do you give? how would you give it? how would you give it يعني PO IM IV؟
IV.
ممتاز excellent okay great. طيب خلينا نشوف البوكس chat box okay. What is the role of magnesium sulfate? Magnesium sulfate works in asthma patient as bronchodilator. يعني smooth muscle relaxant. Okay, it's a smooth muscle relaxant. Okay. Okay. كيتامين برضو. كيتامين ممتاز. الكيتامين له bronchodilatory effect. بس أنا شفت سؤال قبل شوية برجع ودي أشوف. أيوه الدكتورة وفاء سألت when to give ipratropium. دكتورة الاتروفنت هو الابراتروبيوم برومايد. اوكي هو نفسه atrovent is the same as ipratropium bromide. So you start giving it في severe cases. Okay, severe cases. This table shows the different treatment lines of or treatment options of asthma ومع mechanism of actions common side effects. يعني for your reference you can read it later on. Okay, last topic and the asthma patient is a crashing asthmatic patient. Is very important to be familiar with that. Crashing asthmatic patient اللي هم نفسهم impending respiratory arrest اللي تكلمنا عنهم قبل شوي واللي هم يحتاجون intubation. Okay, whenever you intubate the patient, again lung protective strategy. Okay, lung protective strategy. Low tidal volume, low RR, increase inspirative flow rate, decrease IE ratio, plateau pressure طبعا لازم يكون less than 30 والبيب زي ما اتفقنا أقل شيء ممكن إن الماشين كان ست. أحد يقدر يذكرني what is the main goal of lung protective strategy? Why we are setting the machine with these numbers?
To decrease barotrauma.
Excellent. To decrease the risk of barotrauma or pneumothorax. برافو عليك. Okay. One thing is worth to mention هنا في موضوع crashing asthmatic patient. مهم جدا you as emergency physician be familiar with. Okay. اللي هو موضوع something called auto PEEP. Okay. Patient is intubated, initially improved. لكن after a couple of hours the plateau pressure start to give you alarming sound في mechanical ventilator. It says that the plateau pressure ترى more than 30 or the patient repeated vital signs shows hypotension. Okay, هذه signs of auto PEEP. How would you deal with this case? يعني imagine patient asthmatic intubated, he's blunted now, لكن اللي قاعد تشوفه إنه plateau pressure more than 30 and patient is hypotensive. What are you gonna do?
Disconnect him from the machine and squeeze the air out of his chest.
برافو عليك هلا. Excellent. What else? So this is the first thing to do. Excellent.
start
Next.
bagging him and then
Come
consider
again.
any start bagging him and then consider any dislodgement. Check the equipments.
Excellent. So Taif mentioned something very important: increase expiratory time. So you allow exhalation. Okay, you allow exhalation. It's very important. So we basically increase expiratory time. You're trying to get rid out of the air trapped in the alveoli. Different techniques with different طبعا level of effectiveness. عندكم compression of the chest, hugging the chest. Do the technique you like. The أهم شيء عندي, you take that air out of the patient's chest. It's very important. Okay. The third thing is إيش؟ تأكد إنه ما في نيموثوركس. كيف نعرف نيموثوركس؟ كيف نعرف الحالات هذه؟ auscultation ولا JVB ولا بركشن ولا في شيء أهم وأدق؟ CT patient. دكتورة وفاء ممتازة عبد الله. وفاء, البيشنت is crashing. Would you send the patient crashing to CT ولا في شيء كذا نسوي bedside؟ So bedside ultrasound. نعم تفضل.
ايش السؤال دكتور؟ عيد من جديد الله يحفظك.
أقول patient الحين عند هالبيشنت هذا اللي عنده signs of O2P is intubated and patient is sedated, صح ولا لا؟ And we start managing الأوتو هذا اللي عند البيشنت. So we disconnect the ventilator, we allow exhalation, okay, exhalation. لكن جاك زميلك قال لك يا أخي شكل الكيس هذه نيموثوركس. How would you figure it out? How would you diagnose pneumothorax in such patient?
Bedside ultrasound.
Okay, excellent. Bedside ultrasound. هنا يجي قيمة الالتراساوند. يعني one of the best situation where you can utilize ultrasound. طيب. You check ال 8 areas of both lungs, rule out pneumothorax. If the case is pneumothorax, then you insert chest tube. Simple. Okay. And as مين اللي كان يقول لي decrease ال RR and increase flow time. دكتورة طيف. Excellent دكتورة. ممتاز. So decrease the respiratory rate, increase the IE ratio, increase the respiratory flow rate. كلها هذه will balance the patient metabolic status and respiratory status as well. أحد عنده سؤال؟ في سؤال إلى الآن قبل ما نروح لآخر topic؟
So I have a question regarding the big flow meter. How often do we use it in the exacerbation? In some hospitals they don't have it, so
yeah, we use it at first place. Once the patient in bed, before even you prick him, okay, you measure a baseline peak expiratory flow rate during his exacerbation, and you write that down. تكتبها. After that, you start your management based on severity. Okay, you start. Let's say patient عنده severe asthma. You label it as severe asthma. Okay, you start 3 back to back. After you done with 3 back to back, ترجع وتعيد البيك expiratory flow rate وتشوف النمبرز improving ولا getting worse. عشان كذا احنا نقول البيك expiratory flow rate هو أهم وأفضل assessment and reassessment tool عندنا في emergency departments.
Sure, and that table attached it shows an indication له above 12 years of age. So what should we do if the patient is below 12 يعني؟
وين قصدك؟
التيبل البيك فلو ميتر في تيبل كان
هنا؟
ايوه
هذا؟
مكتوب فيها 12 above 12. In case of asthma exacerbation below 12, is it useful to use the big flow meter ولا؟
اوكي فهمت عليك. لا هنا تعاملوا طبعا يدخل في موضوع اللي هو الازمه exacerbation in pediatrics age. هذه لهم طريقه
another severity index.
اي لهم severity index مختلف تماما، وحتى الكت اوفس حقتهم مختلفه. يعني اذا كان الكيد is cooperative enough to perform spirometry الكت اوف مختلفه. and the patient is if the kid is very small يعني ما يقدر يسوي لك expiratory flow meter، في other methods to classify. عادة clinical picture the best way الآن يمشون عليها البيدياتريك emergency consultant is clinical picture. اوكي يعني ما اقدر انا واحد عمره 3 سنوات اقول له سوي لي spirometry. I cannot do that. تتفق معي؟
Yes, sure.
So instead they judge based على the clinical picture of the beats. Let's take a minute to stretch. بعدين نرجع لكم على last topic اللي هو COPD. Okay, moving to the last topic of this presentation, which is COPD. COPD طبعا as compared to asthma, it's a irreversible type of lung inflammatory disease. Okay, and the most important cause of COPD is smoking. Okay, and the most common cause of exacerbation is still unknown. ما أحد يعرف what is the exact cause of COPD exacerbation. Two major types of COPDs. Okay, either blue bloaters, those with chronic bronchitis, or pink puffer اللي هم يجون بالemphysema. Okay. طبعا one important thing is worth to mention هنا إنه one of the worst consequence of COPD is core pulmonale, something called core pulmonale. Core pulmonale increase the mortality rate in patient with chronic bronchitis. So chronic طبعا core pulmonale is associated with chronic bronchitis more than emphysema. This is one thing. The other thing is that's why we give the patient home oxygen. Patient maintained على home oxygen to prevent core pulmonale, therefore decrease the rate of mortality. This is really important. How to diagnose patient with COPD? What do you think? Is pulse oximetry هنا accurate? Well, it's not accurate like in patient with asthma.
Pulmonary function test.
Pulmonary function test. Other thoughts? طبعا أنا أتكلم عن emergency department دكتور ها؟ احنا عادة ال PFT ما نسويها عندنا في الامرجنسي، هذه يحتاج لها طبعا سيت اب، يحتاج لها preparation، يحتاج لها. اوكي. طيب pulse oximetry is the best measure to monitor the response في ال emergency department. Okay. And blood gas, chest x-ray, pro-BNP, troponin, ECG، هذه كلها طبعا I would say it's always indicated. Okay, it's always indicated. A blood gas to classify the severity of the COPD is very important. لأنه based على blood gas value you decide either to start a patient in non-invasive or even invasive intubation. Okay. A chest X-ray is very important to rule out the any causative or any pathology that could lead the patient into COPD. A pro-BNP is very important if إذا أنت شاك في موضوع الهارت failure، في overlap between heart failure exacerbation and COPD exacerbation, and it's not easy to distinguish between the two clinically. That's why pro-BNP has a good value to differentiate between the two. Troponin in case of COPD it has been shown طبعا إنه one of the mortality markers في literature. Okay, so if the patient present with COPD exacerbations having positive troponin with no evidence of ST elevation in MI and normal echo, هذول الناس عندهم mortality rate is very high. ECG, what is the most common finding, or what is the most frequent ECG abnormality in patient with COPD? Okay, atrial fibrillation. Excellent, Dr. Wafa. What else other than atrial fibrillation? Something rarely can be seen, but whenever it's seen, it's really specific. An ECG, multifocal. Excellent, Dr. Zaina. Multifocal atrial tachycardia. Excellent. Good, great. Okay, the things are not recommended in the emergency department, as they don't have any role in the acute setting, is end-tidal CO2 and the spirometry. So these two tests are invaluable in the emergency department. So something not useful at all, by all means. Managing patient with COPD is based on the severity of the case. How to judge on the severity of the COPD exacerbation? The best way is clinical judgment. Okay, the best way is the clinical judgment. يعني patient's comorbidity, patient's clinical status اللي هو patient's look, vital signs. هذه الأشياء هي اللي ممكن تحدد either the COPD exacerbation initially mild, moderate, or life-threatening. Okay, وبased on that طبعا you start your management. طبعا always in any COPD patient we start placing the oxygen patient on oxygen with a target oxygen طبعا 88 to 92%. وطبعا عندنا اللي هو موضوع 3 back to back and IV steroid. Always indicated in all patients. Okay, what's special about the moderate to severe إنه إحنا we consider موضوع non-invasive ventilation BiPAP. Okay, BiPAP is indicated if the patient is hypoxic أو عنده significant tachypnea. وإذا كانت life-threatening again زي asthma patient, if the patient start to show the signs of respiratory failure, at that time طبعا you prepare for intubation, and once you intubate the patient, antibiotic is always indicated. Okay. So there is something called GOLD criteria, indications of giving antibiotic in COPD patient. This is very important. If you decide to admit the patient, antibiotic is indicated for all, whatever the situation. If you want to discharge the patient on antibiotic, you discharge if the patient is having increase in sputum purulence with increase in dyspnea or sputum volume. This is really important. Okay. Or if the patient is intubated, or you plan to start the patient on BiPAP or CPAP, again, this is an indication for starting antibiotic. طبعا what type of antibiotic based على type of exacerbation. عندنا two types of exacerbation, uncomplicated and complicated. إذا uncomplicated طبعا the best antibiotic is azithromycin. If it's complicated, moxifloxacin is the best. طبعا أحد يقدر يقول لي إيش الفرق بين complicated وال uncomplicated exacerbation? What's the difference? What do you think? شكلكم نمتم ها؟
ممكن ال uncomplicated هم ال dischargeable patient stability and maintaining يعني 88 to 92.
Excellent. By other word, complicated exacerbation احنا نقول عليها complicated إذا عندنا suspicious of antibiotic resistance. Okay. إذا عندي risk of antibiotic resistance، يعني مثال إنه patient عنده frequent admissions to the hospital. هذا عنده very high chance of antibiotic resistance، فبالتالي نسميها complicated. Patient needs intubation برضو. This is another risk factor of antibiotic resistance ونعتبره complicated type of COPD exacerbation. ممتاز دكتور. طيب. BiPAP in COPD patient. طبعا this table shows اللي هو موضوع ال indications و how to set up the machine وايش السرفايفل بريدكتورز اللي عندي and what is the evidence. هذه مهمة جدا. كنت تكونوا عارفينها. طبعا ال indication of BiPAP we mentioned it earlier إنه patient is tachypnic أو patient is hypoxic. السيتنج طبعا IE ratio يكون 5 to 2.5 or يعني 215 to 7.5. فعندكم الرينج هذا based على الكلينيكال ريسبونس. بعض الschools suggest to start with the highest IE ratio, then you taper it down till you reach اللي هو الأكسجين تارجت اللي هو 88 to 92. وبعضهم يبدأ بالعكس، يبدأ من اللowest rate بعدين يرفع إلى ما نوصل للتارجت. بس سرفايفل بريدكتور انه بعد ساعه اعيد البي اتش والقاه improved. هذا this is the best survival predictor of COPD exacerbation. طبعا what is the evidence of BiPAP in COPD؟ زي ما اتفقنا قبل انه يقلل المورتاليتي ريت، وهذا اهم شيء عندي. اوكي Okay, that's all we mentioned. Intubation setting تقريبا زي الأزمة patient، ما تفرق كثير. And best way to monitor response طبعا capnography. Okay, زي الأزمة patient بالضبط. وأجين زي ما اتفقنا هنا إنه decision of intubation, BiPAP, stratifying the risk of COPD exacerbation تعتمد كلها على clinical judgment للإمرجنسي physician. طيب أحد يقدر يقول لي what are the factors that associated with good outcome in COPD؟ vaccination. Okay دكتورة طيف excellent. what else؟ في شيء قلناه في البداية وقلنا في complication نخاف منه عشان home oxygen. ممتاز. smoking quitting excellent. what else؟ I think you said it all. Thank you very much. So home oxygen, decrease mortality, smoking cessation, decrease mortality as well. Pulmonary rehabilitation هذه طبعا lifelong or outpatient basis. And vaccinations, mainly pneumococcal influenza. Okay, bravo. Excellent. Okay, these are my references. سامحوني إذا طولنا عليكم، بس pulmonology is a huge bulky part in emergency medicine. لكن I hope this added something to your valuable information. I hope إنه something that you can apply it in real time practice. أسأل الله يوفقكم وييسر لكم يا رب. Do you have any question? Anything in your mind? Okay.
الله يعطيك العافية دكتور.
الله يعافيكم. طيب نبدأ. تبغون ناخذ MCQs ولا خلاص طفشتم؟ نعطيكم MCQs وخلاص. حسكم تعبتم. طيب خلينا ناخذ يمكن معانا دكتورة سلافة.
معاك دكتور.
ايوه what do you think؟ نبدأ MCQs؟
نبدأ MCQs.
يلا. طيب من حاب انه ياخذ الMCQs الأول؟ easy questions easy. دكتور عبد الله؟
نعم.
يلا بسم الله. اكتبوا لي في الشات بوكس what do you think is the right answer؟
هو by Kerb score he will have more than 2 يعني. He will need an admission.
Okay, so the answer is
so it's A.
برافو عليك. excellent. ممتاز ممتاز. حتى في الشات بوكس كلهم متفقين معك. اي برافو. Okay. Who is going to take the second MCQ؟ easy questions يا جماعة.
I'll try again.
لا نشوف أحد غير دكتور عبد الله.
أنا يا دكتور.
مين أنت؟
هلا.
هلا تفضلي. تفضلي. طبعا this is should be on the left side, huh? Just been on the left side, معلش. Not in the right.
I would say my answer is C, and I think the chat also agrees with me.
Okay, excellent. So why C?
There is leveling, air fluid level, and the
Okay.
cavitation and leveling. It's
Okay.
common in alcohol فهذا organism
Excellent.
with self ions.
برافو عليك. Excellent. Excellent. Okay. Thank you, Hala. Okay. You all agree with C. Bravo. طيب. Third MCQ. Who's willing? Third question. دكتورة لما. تفضل.
Yeah.
I will go with deep pulmonary effusion. There is albitration في الكوستوفرينيك angle في leveling وفي كمان اللي هي pulmonary infiltration too.
اوكي فعندك excellent. So دي setting والبيشنت عنده كف وبادي ايك صح؟
Yes.
وفي bilateral infiltrates.
Yes, and also diminished breath sounds confirms the pulmonary effusion too.
Okay. What else? Pleural effusion. You said pleural effusion?
Yes.
Okay. Pleural effusion is a finding. في ممكن عندي clear cause of the pleural effusion هنا.
ايوه اللي هو تحت آخر حاجة في bottom of the right lung.
اوكي. في عندي اللي قصدك obliterated
أيوه.
right costophrenic angle. ممتاز. This is pleural effusion. Agree. لكن pleural effusion this is like a sign. It's not a diagnosis. Okay. And I'm looking for diagnosis هنا. يعني ممكن في شيء ثاني سبب لي pleural effusion as a part of the chest X-ray findings.
Okay. Deep breathing فممكن atypical pneumonia.
Okay, typical pneumonia.
Inspiratory ache.
ممتاز. So the patient is comorbid and the patient عندها 6 days of cough و body ache. صح ولا لا؟ patient is desatting with damaged breath sounds, okay, with no evidence of pneumothorax.
Yes.
هنا أنا أبدأ أفكر مع البايلاترال انفلتريت هذه والبلورال فيوجن أفكر بالفيرال نيمونيا. أوكي أكثر شيء فيرال نيمونيا. طبعا الفيرال نيمونيا تعتبر تايب من الأتيبيكال نيمونيا. أوكي. برافو عليك دكتورة لما يعطيك العافية. Fourth MCQ. خلاص we almost done بس نحتاج همتكم. من حاب يقرأ الفورث MCQ؟
I can go for it.
يا طيب تفضل دكتور عبد الله.
ممكن تكون سي.
اوكي، اللي هي ايش؟ immune reconstitution syndrome. ذكرونا اللي قلنا هذه it's rare ولكنها reassuring kind of syndrome that could happen after initiating اللي هو الانتي تي بي ثيرابي، صح؟ وقلنا
سي دي 4 لو.
أيوة. ممتاز. how do you manage this case؟ you ask them to resume، صح؟ يكمل ولا يوقف الانتي تي بي؟
they have to continue.
they have to continue ونطلع على ايش؟ simply paracetamol. اوكي paracetamol so supportive therapy and well hydration يعني good hydration. يعطيك العافيه دكتور عبد الله. last MCQ. نحتاج أحد كذا ما سمعنا صوته ولا إذا ممكن. إيزي، أوعدكم إنه بيكون سؤال مرة سهل.
يلا هاي القوة.
أوكي يلا لوي.
دي.
لؤي يقول دي. What do you think؟
نيموثوراكس.
Pneumothorax. Why دي؟
باركود ساين.
Excellent. Barcode sign and the M mode. Excellent. Good. Okay. يعطيكم ألف عافية. Thank you very much for your attention, your participation. بصراحة يعني أنا أتمنى أنها كانت fruitful educational one. وزي ما اتفقنا يعني هذه الأشياء always keep it in mind. وهذا طبعا خلينا نقول يعني most important information from emergency point of view that you could apply one day in emergency grant. فدائما يا جماعة keep it in mind. هذه الأشياء ترى هذه مرة شورت كاتت، هذه يعني مرة شورت كات. ف يعني أتمنى أنكم استفدتم وأتمنى أني ما ثقلت عليكم. و if you have any question feel free at any time. الله يحييكم. ف البرزنتيشن الدكتورة وفاء موجودة مع الدكتورة سلافة. she can share it with you.
يعطيك ألف عافية دكتور، وشكرا لجهودك، شكرا لتعليمك.
لا شكر على واجب. موجودين anytime. الله يوفقكم، يا رب ييسر لكم.